Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO! This episode is our first episode on palliative care. Today we're going to be discussing basics of palliative care and the management of cancer-related symptoms. Our learning objectives are to review the rationale and guidelines for incorporating palliative care into gynecologic oncology and to discuss the management of cancer-related symptoms such as pain, nausea and vomiting, constipation, fatigue, anorexia, cachexia syndrome, grief, and depression. We want to start by providing a framework for what palliative care is and what it isn't. Palliative care is an approach to care which prioritizes the management of symptoms in a patient-centered way, incorporating the patients and their loved ones' values, beliefs, and cultures to help patients meet their quality of life goals. Palliative care is not synonymous with hospice care, which is supportive care measures recommended for patients at the end of life. Palliative care measures and approaches can and should be incorporated throughout the patient's disease course and can be incorporated while patients are still receiving cancer-directed therapies. From the NCCN, the goal of palliative care is, quote, to anticipate, prevent, and reduce suffering, promote adaptive coping, support the best quality of life for patients, families, and caregivers, regardless of the stage of the disease. With this framework in mind, it's clear that palliative care is part of the practice of gynecologic oncology. While we often involve our palliative care specialists for complicated scenarios, we should feel comfortable incorporating palliative care practices into clinical care as well. The NCCN is a great place to start to talk through palliative care for our patients. They have a set of guidelines specifically for palliative care, and they also have separate guidelines for management of specific symptoms like pain, nausea and vomiting, fatigue, distress, etc., all listed under the headline of supportive care. It's very helpful to have these in our back pocket. As part of the NCCN palliative care guidelines, all patients with cancer should be screened for palliative care needs at the first visit and then as needed throughout their care. Evidence shows that utilizing a palliative care approach throughout the cancer care continuum is associated with an improved quality of life, symptom management, and improved quality of end-of-life care. It's important to educate patients about palliative care and emphasize that it does not mean end-of-life care, as this can be a source of confusion and distress. Several studies have also shown an improvement in overall survival with early integration of palliative care. The ENABLE-3 trial, published in 2015, was a phase 3 trial which looked at outcomes for patients with advanced cancer after early versus delayed initiation of palliative care. The 1-year survival rates were higher in the early palliative care group, and there was decreased depression and stress burden in the caregivers. However, there was no difference in patient-reported quality of life, symptom impact, or mood compared to 3-month delayed initiation. Other studies show incorporation of early palliative care is associated with decreased use of aggressive care measures at the end of life and has been associated with decreased healthcare costs for patients over their disease course. A systematic review showed that the best outcomes are seen when palliative care is integrated within 8 weeks of diagnosis. As part of this initial assessment, we should be asking patients about symptom severity and control, distress, comorbidities including functional status and decision-making capacity, psychosocial and spiritual needs, cultural factors affecting care, social determinants of health like financial toxicity, concerns about disease course, and decision-making. Other indications for involvement of palliative care can include requests for hastened death, poor prognosis, and worsening prognosis. The acronym TEAM is used to describe the approach to palliative care: time, an extra hour per month, education, assessments, and management with an interprofessional team. Palliative care can be delivered in an outpatient setting and in an inpatient setting, often with different overarching goals. Ideally, patients will get introduced to palliative care and have an initial consultation outpatient where a holistic approach to symptom management and optimization can be started. Often, palliative care can help us manage patients with complex pain symptomatology, refractory nausea or vomiting, or other symptoms we'll talk about below in the outpatient setting. Inpatient, palliative care practitioners can be excellent consultants to help optimize symptoms in our hospitalized patients. They can consult throughout the spectrum of a patient's care, from post-operative symptom optimization to end-of-life care. If your hospital has an inpatient hospice program, the palliative care service would typically manage that service. We'll discuss more end-of-life delivery of symptom-directed care in our next episode. Let's first talk about symptom management, and at the end of this episode, we'll talk about goals of care discussions and code discussions. So again, the NCCN palliative care guidelines have excellent separate sets of guidelines for symptom management, and even have a palliative care drug appendix that goes into detail about medications to choose for symptoms based on life expectancy, symptom specifics, and comorbidities. Let's first talk about pain management. Patients with gynecologic cancer can have acute pain due to surgery or another specific cause, or chronic pain related to their cancer, their treatments, or due to other reasons. A patient's total pain describes the cumulative pain that patients are experiencing and can include physical, spiritual, psychological, and social pain, with a lot of overlap between categories. When thinking about how to manage pain, it's crucial to identify the source, contributing or exacerbating factors, and the chronicity of the pain. We'll start first by talking about neuropathic pain. Neuropathy related to chemotherapy can cause significant pain. The pain stems from damage of the somatosensory nervous system, which leads to abnormal neural excitability. Additionally, patients can have neuropathic pain due to nerve compression from growing tumors. This pain can take various forms, presenting with numbness, burning, tingling or prickling, or dysesthesias. Non-opioid medications are the first-line therapy for neuropathic pain, with duloxetine being the first-line choice. Duloxetine is an SNRI and is the only medical management option that improves patient-reported scores for pain, function, and quality of life. The starting dose for duloxetine is 20 to 30 milligrams daily, titrating up to 60 milligrams daily. Desipramine is a secondary tricyclic antidepressant and is another option. Gabapentin can be a helpful adjunct as long as patients don't have depressed mood. Start at 100 to 300 milligrams nightly and titrate up. Remember that the usual effective dose range for neuropathic pain is between 300 to 1200 milligrams 3 times a day, so the starting dose will not be effective. Be patient. With higher doses, patients can experience significant bothersome sedation and dulling of the senses. Other medications for neuropathic pain include other anticonvulsants, oral analgesics like cannabinoids and alpha-2 adrenergic agonists, topical analgesics like lidocaine and botulinum toxin injection, and other options like ketamine, an NMDA receptor antagonist, and baclofen, a GABA receptor agonist. Finally, opioids can reduce neuropathic pain by 33%. Methadone was thought to be a potential medication for neuropathic pain, but a Cochrane review concluded there was not enough evidence to support methadone use for this indication. Plus, due to the long half-life, it's tricky to prescribe. We mentioned that opioids aren't first line for neuropathic pain, but they are first line for chronic cancer-related pain. Maya, can you walk us through how to use opioids in our practice?
Absolutely. We could probably do an entire lecture on this topic, but we're going to keep this brief and try to hit the high points. Hopefully, a lot of this will be review. When prescribing opioids, it's important to think about the type of pain, the patient's current use of opioids, and whether a patient has chronic opioid tolerance. Let's first talk about acute pain management with multimodal analgesia, incorporating opioids after surgery. Remember that our standard should be to have scheduled administration of over-the-counter analgesics like Tylenol and ibuprofen, and sometimes other medications like gabapentin or muscle relaxants, with opioids reserved for pain that's not well controlled with these agents. Regional anesthesia like epidurals can also be helpful, and surgeon-administered local anesthetic like liposomal bupivacaine or transversus abdominis plain blocks or TAP blocks can also improve incisional pain and further reduce the amount of opioids needed. These multimodal agents are all a part of our ERAS principles, and the ERAS guidelines specific to gynecologic oncology are another helpful place to gather information. It's a well-known, well-published fact that physicians overprescribe opioids at the time of discharge from surgery, and there are some techniques to approach this. One technique is to just ask the patient how many tablets they think they'll need. In a study published by the University of Michigan, this significantly reduced the number of tablets prescribed, and the majority of patients still had leftover tabs. Another option is to have a standard number of tablets prescribed for each procedure, with a lower starting prescription, while letting patients know that you can send more if they need more. New persistent opioid use or dependence occurs in 6% of postoperative patients, and we should think about this like a surgical complication. If patients weren't on opioids before surgery, our goal should be to have them off opioids after their acute recovery period. I mentioned over-the-counter analgesics. I'm sure we've all had patients who report that over-the-counter meds don't work for them, and there can be significant resistance to these. One way to help patients feel invested in over-the-counter meds is to discuss the mechanism of action of each medication and how they target different pieces of the pain response. Taking these regularly can help reduce the number of opioids needed. Of course, make sure to check patient comorbidities and ensure there are no contraindications to any prescribed medications. Sydney, what about managing chronic and uncontrolled pain with opioids? Are there some general guidelines for choosing the right dose, route, and dosing frequency?
There are. Many patients with chronic cancer pain will require opioids for pain management, and triggers like disease progression, a procedure, infection, or necrosis of a tumor can increase their opioid needs acutely. Sometimes this can be managed outpatient with up titration of long or short acting medications, but sometimes it requires the use of IV opioids in the hospital. Today, we want to talk about some guidelines for management of a pain crisis, including utilization of IV, oral, and transdermal opioids, and how to transition patients back to non IV modalities when they're returning home. A lot of the discussion we'll have today revolves around some helpful calculations: total opioids delivered in the last 24 hours, and the concept of oral morphine equivalents. Remember that depending on the agent and mode of administration, each opioid has an oral morphine equivalent. Most patients aren't taking just oral morphine, and so equivalency charts available in multiple places should be used to convert all opioids given to a total oral morphine equivalent over the last 12 or 24 hours. Recognize that the PO and IV options for the same drug, such as Dilaudid, will have different OMEs. Converting to oral morphine equivalents will help you understand where that patient is at for immediate and future opioid prescriptions. We'll post an oral morphine equivalency chart on our website. When evaluating patients with uncontrolled pain, you should consider the source and the reason it's uncontrolled. Is it that the dose of medication given isn't adequately controlling the pain, or is it that the dose controls the pain initially but doesn't last long enough? For patients with a pain crisis, if their pain is not adequately controlled with the medication you have been giving, the NCCN recommends giving either an IV or an immediate release oral opioid. For immediate release opioids, the peak effect occurs 60 minutes after administration. If giving an IV opioid bolus, the peak effect will occur 15 minutes after the dose is given, and this is 30 minutes for a subcutaneous bolus. If patients are opioid tolerant, you can start with an initial dose which amounts to 10 to 20% of the total opioid taken in the previous 24 hours. Reassess your patient's pain at the time of peak effect, so 15 minutes for an IV dose or 60 minutes for an oral dose, and assess what the effect was. Was it improved but not enough, unchanged or worsening, or improved and adequately controlled? You can then decide to repeat the same dose at that point, increase the dose by 50 to 100%, or continue with the dose and schedule. Be wary of stacking opioids, giving doses soon after the other before the peak effect, as the cumulative effect of doses can lead to sedation or even overdose. Maya, how else do we incorporate IV opioids into pain management for our cancer patients?
Some patients will require the use of a patient-controlled analgesia or PCA pump. The stacking effect is also crucial to think about when creating dosing intervals for PCAs. Typically, PCAs include a combination of patient-delivered boluses, nurse or provider-delivered boluses, and in cancer patients might include a basal rate. You'll set the baseline dose for the boluses as well as the basal rate, and will have to choose a lockout interval between boluses. Typically, the nurse dose should be about twice the patient-delivered dose because those should be reserved or given only for uncontrolled pain. The lockout should not be more frequent than 15 minutes because of that maximum effect timeline for IV opioids that we've discussed. If you think patients need more, you can increase the bolus dose or the basal rate instead. As we'll discuss in our next episode, this lockout interval can be shortened at the end of life. While doing this titration and adjustment, it's important to set clear goals for pain management for our patients. The goal shouldn't be for the patient to have zero pain, but rather for the pain to be tolerable for patients to perform activities of daily living and to do things necessary for recovery. So once we get our patient's pain adequately controlled with a combination of IV doses and the long-acting oral opioids they were already taking, and their pain stays well controlled, we then need to switch them over to a regimen that they can go home on. What we first want to do is calculate their total oral morphine equivalents, or OMEs, over the last 24 hours as previously discussed. When transitioning away from IV meds, usually you prescribe a total OME that's reduced between 25 to 50% from the dose they were taking through the IV. This can be titrated in the outpatient setting, but it avoids overprescribing. If you anticipate that patients will need ongoing opioid medications, often the dose should be split between long-acting scheduled opioids and short-acting as-needed doses. When choosing agents, cross-check individual opioids with patients' comorbidities. Consider the effects on renal and liver function, and avoid using opioid products that are combined with other agents like Tylenol, as this can make titration challenging. I think that's all we've got for opioids today. Remember that multimodal analgesia is best, and things like regional or neuraxial analgesia can be incorporated. There are also more invasive pain control options for specific indications, like a hypogastric plexus neurolysis, utilized for those with neuropathic pain which doesn't respond to or is not amenable to conservative options, or an ablative spinal procedure like a cordotomy for patients with unilateral cancer pain. Both of these really should be limited to patients with short life expectancies. Okay, Sydney, can you move us on to the next symptom?
So, next, we're going to talk about nausea and vomiting. Up to 50% of advanced cancer patients will experience significant nausea and vomiting, and understanding the underlying mechanism is crucial to appropriate treatment. The VOMIT acronym can help you run through your differential diagnosis. Vestibular, obstruction or constipation, dysmotility, infection or inflammation, and toxins can all contribute to nausea. By identifying the root cause, you can choose the appropriate medications to target the relevant receptors. Acute chemotherapy-induced nausea and vomiting is defined as occurring within 24 hours of administration, and delayed CINV is greater than 24 hours. Anticipatory chemo-induced nausea vomiting is a pre-chemo response after having a prior episode. Different agents are associated with different risks of chemo-induced nausea and vomiting. High emetogenicity is defined as greater than 90% chance of acute CINV, with moderate at 30 to 90% and low at 10 to 30%. Highly emetogenic IV chemos using GynOnc include cisplatin, carboplatin AUC greater than 4, cyclophosphamide, dacarbazine, doxorubicin greater than 60 milligrams per meter squared, ifosfamide greater than 2 grams per meter squared, and Enhertu. For our standard chemotherapy regimen of carbotaxol, which has a high emetogenic potential, a 3-drug combo is common practice. This usually includes a steroid like dexamethasone, an NK1 receptor antagonist like aprepitant, and a 5-HT3 blocker like ondansetron. Let's talk about why.
A little bit of neuroscience. The chemoreceptor trigger zone is located in the area postrema and nucleus tractus solitarius in the dorsal brainstem outside of the blood-brain barrier. This receives inputs from the vagal and splanchnic nerves and directs inputs from the blood and CSF. It relays signals to the vomiting center, or the central pattern generator in the medulla, which then communicates to the vagal nerves, triggering emesis. There are two main pathways for chemo-induced nausea and vomiting: the peripheral pathway and central pathway. The peripheral mechanism results from the release of serotonin from enterochromaffin cells of the small intestine, which binds to the 5-HT3 receptors of the vagal and splanchnic nerves and is responsible for acute chemo-induced nausea and vomiting. Alternatively, the central mechanism is related to the release of substance P, which binds to NK1 receptors in the central nervous system and results in delayed chemo-induced nausea and vomiting. Thus, a timeline of symptoms may help you more effectively manage these symptoms as they arise. For example, aprepitant given PO or fosaprepitant given IV, which both target the central NK1 receptor, have been shown to be more efficacious for delayed chemo-induced nausea and vomiting. They're used to prevent acute and delayed emesis, typically in combination with serotonin receptor antagonists and glucocorticoids. They're an inhibitor of the CYP3A4 pathway, and so glucocorticoids have to be dose reduced. Serotonin receptor 5-HT3 antagonists are the most commonly used. First-generation agents include ondansetron, granisetron, and dolasetron. Palliative has a high binding affinity and has a longer half-life. Granisetron also has an extended release formulation. These agents can cause headaches, dizziness, and constipation, so keep this in your differential. They can also lead to QTC prolongation and can be associated with serotonin syndrome, particularly in patients who are using SSRIs or SNRIs.
Nausea and vomiting related to cancer can also come from sources not directly related to chemotherapy. For example, infection and inflammation can be targeted by blocking the histaminic, cholinergic, and 5-HT3 receptors in the GI tract. Toxins, including drugs and metabolic products, trigger the central dopamine receptors, 5-HT3 receptors, and NK1 receptors. Nausea related to gut dysmotility involves multiple receptor pathways, including dopamine receptors. The stipular causes of nausea involve the acetylcholine and histamine receptors. Make sure to think about which mode of administration will work for your patients based on the perceived triggers of nausea. If using multimodal therapy, you should have something scheduled and something available PRN, and make sure you're using agents from different classes. Typical antipsychotics target dopamine receptors and include prochlorperazine, haloperidol, and metoclopramide. If using a medication originally developed as an antipsychotic, explaining to patients that you're using it for nausea may help avoid hesitancy about initiating these medications. The starting dose for haloperidol is 0.5 to 1 milligrams PO or IV. Haloperidol doesn't decrease gut motility or cause sedation like other antiemetics. Metoclopramide stimulates 5-HT4 receptors as well as dopamine receptors and can be good for nausea related to dysmotility. All of these medications can cause extrapyramidal symptoms or acute dystonia, the treatment of which is diphenhydramine. Haloperidol can cause QTC prolongation, but not typically at the doses used for antiemesis. Olanzapine is an atypical antipsychotic which targets both the 5-HT2 and D2 receptors. It can cause sedation and drowsiness, so start with a nighttime dose. It can also cause transaminitis, hyperglycemia, and dyslipidemia, so continue to monitor labs. It can stimulate appetite, so this may be a good adjunct for those with cancer-related anorexia. More to come on that later. Scopolamine, acetylcholine targeting, and phenergan and meclizine, both histamine targeting, are good for vestibular causes of nausea. Finally, laxatives can be selectively helpful if nausea is related to constipation. Benzodiazepines do not have a routine role in nausea or vomiting unless it's anxiety-related anticipatory nausea related to an upcoming procedure or infusion.
On that note, let's talk about constipation. Prevention is ideal here. If patients are on medications like opioids or Zofran, or if they have other risk factors like dehydration or a low-fiber diet, be proactive. Opioid constipation does not improve with time, so prevention and early management is key. Like with nausea, it's really important to take a good history and understand specifically what the symptoms are, what the etiology is, and how the symptoms or bowel habits relate to their normal pattern. A goal should be to have a formed, soft bowel movement that doesn't require straining every 1 to 2 days, but this can be different depending on what their norm is. Make sure you rule out fecal impaction and bowel obstruction before treating someone for constipation. Laxatives are the mainstay of treatment for constipation, and the mechanism of action is key. Stimulant laxatives include Senna and Dulcolax. These have a relatively fast onset of action. As we discussed, prevention is key, and one of these should be prescribed whenever you write an opioid prescription. The maximum dose of Senna is 6 tabs twice a day. A good starting dose is 2 tabs at bedtime. Osmotic laxatives include Miralax, lactulose, milk of magnesia, magnesium citrate, and sorbitol. Because of the mechanism of action for these meds, they need to be taken with water or increased hydration to allow them to work. If patients are struggling with satiety, these might be more challenging to tolerate. Magnesium citrate should be avoided in renal insufficiency. Consider combining meds with 2 different mechanisms of action to maximize, if you ever need more than one agent. Cholase is a stool softener, which has been shown to be ineffective as a single agent. Also, in studies where cholase was combined with senna, there wasn't much added benefit from addition of cholase. It does make the stool softer, so it could help with pain with defecation, but it's not very effective for constipation. Suppositories like bisacodyl and glycerin can be helpful adjuncts and have about a 15-minute onset of action. Enemas are another option. Keep in mind that Fleet's enemas with electrolytes contain sodium phosphate and can lead to hyperphosphatemia, especially in the setting of renal failure. Finally, mu-opioid receptor antagonists like alvimipan and methylnaltrexone, brand name Relistor, can be employed for opioid-related constipation. These are expensive agents. Alvimipan specifically needs to be given before a patient has any exposure to opioids, while methylnaltrexone is something you can use when previous agents have failed. They're both contraindicated in the setting of a bowel obstruction. If patients have a bowel obstruction, it's also best to avoid gut stimulation and stimulating agents, and you should avoid azofran as it can slow down gut motility and worsen symptoms. Sydney, can you tell us about cancer-related anorexia and cachexia syndrome?
Yes. Anorexia and cachexia can occur independently from each other, so patients may develop cachexia with physical wasting and loss of muscle mass, even with preserved appetite and caloric intake. This is due to elevated inflammatory cytokines and tumor-derived factors which cause proteolysis of muscles. Make sure to do a thorough evaluation of the cause of the anorexia. Are there symptoms that are interfering with the patient's ability to eat, like dry mouth, jaw or dental issues, GERD, oropharyngeal candidiasis, pain, early satiety, depression, nausea, constipation, fatigue? Do an exam and make sure to look for thrush related to immunocompromised state, especially if there's a pain component. If there are reversible causes, treat these first. The approach to management depends on the patient's prognosis and goals of care. For patients with years or years to months of expected life left, it's important to address reversible causes, including whether medications are contributing to anorexia and if these can be adjusted. Consider a dietitian consult, psychiatric consultation, or nutrition support. Appetite stimulation is usually reserved if these interventions don't work. Interventions can include pharmacologic and non-pharmacologic measures. Nutrition consultation can be helpful for improved quality of life. Patients are recommended to eat small, frequent, calorie-dense meals with high protein supplementation. If patients have gastroparesis or slow gut, metoclopramide can address early satiety. If it's isolated anorexia, olanzapine and dexamethasone can both increase appetite. Olanzapine dosing is 2.5 to 5 milligrams daily, and dexamethasone dosing is 3 to 8 milligrams daily. The ASCO guidelines on management of cancer-related cachexia endorse a short-term trial of low-dose corticosteroids to improve appetite, but note that they are not likely to improve weight. They state that benefit will likely be reserved for patients with a prognosis of weeks to short months. Megace has traditionally been considered as an appetite stimulant, but studies do not show improvement in quality of life, show rare increases in weight, and there's an increased risk of thromboembolism and even death with higher doses. This medication has been removed from the NCCN guidelines. Cannabinoids are another class that have been utilized for this reason, and there's limited data about efficacy in cancer patients. Some studies showed no benefit, and other studies comparing cannabinoids to megace showed megace to be better. Cannabinoids can also induce delirium, especially in older patients. If patients have anorexia symptoms and depression, mirtazapine can help with appetite, mood, and sleep. It's also important to educate patients and their families on anorexia symptoms and cancer. Anorexia is not uncomfortable, especially at the end of life, and it is different than starvation. For patients with a months to weeks or less life expectancy, the focus should be on patient comfort. We'll talk about nutrition at the end of life in our next episode. We didn't talk about artificial nutrition. Generally, artificial nutrition is not recommended as it can increase infection, does not improve survival, and does not improve quality of life. Rare exceptions for prolonged anorexia or NPO status in a post-op patient or other patient with good prognosis who is expected to regain ability to self-feed or sustain can be made.
Fatigue is another symptom in which management strongly depends on prognosis. Cancer-related fatigue is the most common symptom in patients undergoing cancer treatment, and up to 80% of our patients will experience this. The most important piece, like with anorexia, is to assess and manage any modifiable underlying causes. Management should always start with non-pharmacologic interventions, which can include behavioral modifications like expectation setting, energy conservation techniques, and the addition of exercise. While this might sound counterintuitive in patients who feel fatigued, this is a Category 1 recommendation and is the most effective treatment for cancer-related fatigue. Yoga, massage, and cognitive behavioral therapies can also be helpful. If these measures are unsuccessful, then pharmacologic agents can be considered. Stimulants like methylphenidate are typically used, but some patients won't like the side effects or the way that they feel. Patients can take these PRN for days when they need extra energy, or they could take it every day. Steroids should only be incorporated at the end of life and only for short-term use. Sydney, I know a lot of patients have sadness and grief related to their cancer diagnosis. How do we distinguish this from true depression?
Good and important question. Formal validated screening tools like the PHQ-2 with the PHQ-9 if positive should be utilized, as well as talking with our patients. Ask your patients if they're experiencing mostly bad days or a combination of bad and good days. You can also ask people directly if they think they might be depressed. Often patients will have a more clear answer to this than you might expect. If patients meet criteria for depression, they should be treated with standard of care therapies, including non-pharmacologic and pharmacologic interventions. The last symptom we want to talk about are sleep-wake disturbances, specifically delirium. This often occurs in the evening, especially among older hospitalized patients. It can fluctuate throughout the day. Prevention is key here, with good sleep hygiene while patients are in the hospital, meaning lights off at night, shades open in the day, and minimize disruptions overnight. Sometimes delirium will present like a clinical change in a patient's status, so keep it on your differential diagnosis. Benzodiazepines can be a big trigger for delirium and should be avoided in the hospital if possible. Treatment is similar to prevention, with the addition of reorientation to delirium precautions. Typically, pharmacologic therapy is avoided unless there is a threat of harm to the patient or others, and haloperidol is first line. The dosing is the same as for nausea, 0.5 to 1 milligrams either orally or IV. That's all we have for you today. We hope you learned something on today's episode of Ready Set GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode.
Palliative care is an approach to cancer care which prioritizes the patient's symptoms, values, and quality of life goals. Palliative care can and should be incorporated early on in conjunction with cancer-directed therapies and in this way, it differs from hospice care. Early integration of palliative care has been associated with improved overall survival, in addition to decreased symptom intensity, improved quality of life, and decreased healthcare costs, as well as decreased use of aggressive care at the end of life. The NCCN has a specific set of guidelines for palliative care, including components which should be incorporated early on.
Nearly all of our patients will experience bothersome symptoms related to their cancer or treatment received. Symptoms include, but are certainly not limited to, pain, nausea, vomiting, constipation, fatigue, anorexia, cachexia syndrome, grief, and depression. To manage symptoms effectively, it's crucial to think about the root cause. For example, in patients with nausea, knowing the source can tell us which receptors are being aggravated and help us to choose the correct therapies. For pain, nausea, and vomiting, and constipation, a multimodal approach incorporating different mechanisms of action is key.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson. We'd like to thank Dr. Janelle Sobecki, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.